Hello, everyone. Welcome back to another episode of CRNA School Prep Academy podcast. I am your host, Jenny Fennell, and today we're going to talk about maintenance of anesthesia. I know on the last episode, we had talked about induction. There's also an episode on preoperative assessment. So if you haven't listened to those two, I encourage you to do that first before you dive into the maintenance of anesthesia. But today, again, we're going to kind of go over what all is involved in maintaining anesthesia and maybe kind of how it looks different depending on what type of anesthetic you're providing. So let's go ahead and get into today's show. So essentially, this phase comes immediately following the induction of anesthesia. And, the induction of anesthesia kind of ends with the transition into the maintenance of anesthesia. Probably one of the first things I should say that you kind of start doing after the induction that kind of starts going into the maintenance of anesthesia, and that's really important to do, is the positioning of the patient. And I know I mentioned this during the induction, that you should always obviously ask the patient prior to going to sleep if they're comfortable, because again, if you're not going to really be repositioning them after they're asleep, it's important to make sure that they're going to bed comfortable or going to sleep comfortable, because if their back's hurting, they're going to wake up with back pain. And even if they're not operating on their back, that's not fun for the patient to have arm surgery, wake up with low back pain. So doing little things like putting a pillow under the knees, again, taking that time to ask the patient when they're on the table if they're actually comfortable. Sometimes they need 3 or 4 different pillows. Maybe they have, some issues with their neck. And so again, making sure that they're comfortable prior to going to sleep is really key. However, sometimes after you go to sleep, you reposition the patient. Okay. And so whether you're going lateral, prone, there's all different types of positions that you could be going into after your sleep, jackknife. There's several different, like I said, considerations you want to make sure you're taking into consideration, such as making sure that their pressure points are padded, making sure that their eyes are free from pressure, making sure that their neck is neutral. And so positioning is one of the first key things you do in the maintenance phase of anesthesia, because sometimes you're actually doing the vast majority of positioning after they're asleep and after induction's already done. And once the surgeon starts operating, you can't really do a whole lot with positioning. Now, don't get me wrong, you can adjust an arm board or an arm, or you have access to the head. If their feet, you can have access to the feet, but depending on what the operation is, you may not have a whole lot of access to the patient after they're draped and sterile. So it's really important that you're moving EKG leads during this time, if you have to get them out of the surgical field, or making sure that, again, they're in a good position so they're not going to get stuck to the drapes. Because again, once the drapes are on the patient, it's really hard to do these things at that moment. So taking that into consideration. So after you position a patient, let's say you're going lateral, and let's say you put the EKG leads on in a position such that when you go lateral, they get ripped off. Okay. So that's what I mean. Think about these things prior to actually doing them, and you'll make your life a lot easier. However, not that it's the end of the world to reposition an EKG lead before they actually start prepping the patient, but that should be one of the first things you do, because again, once they actually start prepping the patient, you're going to be in their way. You're going to, potentially have to make them re-sterilize the patient if you mess up their sterile prep. So again, positioning the patient should be one of the first things you do. Again, I mentioned checking eyes, checking their neck, checking their pressure points, and that includes like their shoulder and their elbow area, because those are very common areas to injure. And so making sure the hand is supinated, making sure the shoulder's not higher or extended greater than 90 degrees. Again, making sure their neck is neutral. I mean, think about it. If your neck's laying like this the whole case, you're going to have a brachial plexus injury, because you're going to be stretching that brachial plexus. Okay. And so making sure their neck is actually neutral, making sure their ear is not folded over like this, for those of you who are watching this in the pot or the YouTube, you can see this. But again, if you turn someone lateral, their ear could be smushed. And can you imagine laying on a smushed ear for like 4 hours? Yeah, you don't want to do that. So a lot of times you have like a little circle donut, and make sure their ear fits nicely in the circle donut area. Again, making sure that you're not having something pushing on the eyeball, like even if it's a foam padding, you don't want foam padding pushing on someone's eyeball for hours, okay? Because that can really do a lot of damage. So making sure that their eyes are free from pressure, especially if you're prone, you really need to be checking those eyes if you're prone. And same with all other things, their neck, if they're in a modified diving position, where are their shoulders in relative to their body, to make sure that you're not, again, going to be stretching that brachial plexus. Where are their elbows, is their hand extended out like this, or is it more like this? You want to make sure, again, and try to put yourself in their position. If you were laying in that position, if it doesn't look comfortable, chances are it's not going to be comfortable. I always like if their hands are out, like to kind of support their hands. So you're not, laying on closed fists the whole time. Cause think about it, like your fingers will probably go to sleep if you're clenched like this and laying on your fingers. So get their fingers out, put a nice little roll underneath their fist. So they're supported. One of the other really huge things with positioning, you guys, is your IV access. Okay. Your IV is your lifeline. Okay. It's what you need if something were to happen. It's how you give drugs. It's how you keep them physically and hemodynamically stable during the case. So it's at utmost importance that you double and triple check this prior to them draping and getting too far into the case. Okay. Because the last thing you want to do is have to crawl underneath the drapes and fiddle with an IV. That's positional. If you take the extra time prior to them draping to make sure you're taping the IV so that it runs smoothly, you're going to make your life a whole lot easier than trying to get under the drapes and doing it and irritating the surgeon that he has to stop operating because you don't have an IV. Something to keep in mind too with the whole IV is if the arms are going to be tucked and you don't have access to troubleshoot the IV, they'll tuck the arms such that, you guys, that literally their whole arm is wrapped into a blanket and tucked into the side. So it's extremely hard to get to the IV site once that has occurred. So when that happens, it's always best practice to have 2 IVs. These could be cases like an ACDNF, which is an anterior cervical fusion. It could be cases like a robotic case where, again, once the robot's docked, it's going to be very hard to have access to the patient. Any surgery where their arms are tucked, it's always good practice to have a second IV. It could even be a thyroid. I know you don't have a heavy blood loss in a thyroid, but if you lose your one IV access, well, what's your plan then? Because you're going to need an IV. And I've had surgeons hit an EJ during, or an IJ during a thyroid before. I mean, stuff does happen and you will need good IV access if something goes unexpected. There's been cases where, maybe I've had to go to the foot because I don't have access to the arms anymore and I need another IV. And now I'm starting an IV in a foot, which really isn't an ideal place to start an IV. So make sure you're thinking about those things when you're positioning your patient and check your IVs, make sure they run. I used to tell my students, tape the rainbow. You can call it a loop. You don't have to call it a rainbow. I just had fun with calling it a rainbow, but it's the loop in the IV. So like, let's just say you start an IV in the forearm or the hand and you have a loop. Okay. Notoriously, when you're underneath a bear hugger, underneath the drapes and all the blankets, it's going to get warm under there. Okay. And when things get warm, when the IV line gets warm, it makes it more pliable. It makes it less stiff. And so naturally, when that happens, that loop just gets kinked. And so you're not going to be able to push through your IV. You're like, man, is my IV bad? What's going on? It's because when it gets warm under there, that IV is going to bend and collapse because it's now soft and warm and squishy. So taping that, I say tape the rainbow. You just put a piece of tape to reinforce the strength of that curve. And so it's less likely to kink and become an issue. So doing that, again, sometimes if you start, that's why I don't think any anesthesia provider likes ACIVs. However, especially like at the surgery center I worked at, it was like the favorite place to put IVs was in their AC, their antecubital, which was so annoying because those are just the worst IVs, because if the patient bends their arm at all, it doesn't work. It's just obnoxious. But again, if you have an AC IV, making sure you're taking the time to position the patient's arm so that it's going to run during the case. Okay. Sometimes IVs can be positional, or maybe they're up against the valve a little bit. So you have to actually put some backward torque or tension on the IV to get it to run. And what you do is you take a piece of tape and you pull backwards on the IV just a little bit, tape it that way. So that way you have that little bit of tension all the time. I used to also have extra rolls, or like a 4x4 that I would like roll up and put some extra tension on an IV to cause that backward tension, or even like an A line, for example, that was positional. You would want to make sure whatever position you're putting the patient in, that it was working. So like if it was an A line, and if they had their arms tucked, sometimes I'd have to almost extend the wrist out like this to get it. And I know you guys can't see me on the podcast, but I'm kind of extending the wrist a little bit to make sure that it wasn't getting kinked. So if the wrist is bent this way or maybe straight, sometimes the A line would actually get kinked. So you'd have to put a little bit of extension. And to do that, you would just get a roll and put it right behind the wrist. Okay. And that's all you would do. It'd be enough to kind of keep that tension there. Because when the surgeon leans into the body of the patient as they're operating, naturally they're going to push on the wrist, and then you're going to lose your A line. And that stinks, right? Especially if it's during a part of the case that you really need to continuously watch their blood pressure, like they're in an open heart, where they're getting ready to cannulate the aorta. So it was always critical that we double and triple check to make sure that the A line was not going to be positional. And if it was going to be positional, which again, I'm going to get into a little bit later on about the maintenance phase, is communication, you guys. Communication is obviously important no matter what phase of anesthesia you're in, but you have to communicate. You have to say, hey, we have an A line, but it's positional, or hey, we have this IV. It's the only IV we have. What do you think the blood loss? What do you think the blood loss is going to be like? Is it okay if I start a second IV? And this is my concern. It's positional. If you get any kind of blood loss, we're going to be in trouble. Can we untuck the arm and start a second IV? Because maybe you thought you were going to be fine. Or maybe you thought you'd have better access, and all of a sudden your one IV that you have, even though it's a good IV, is now positional. You just have to communicate this with the surgeon, let them know. Obviously, everyone is going to have the patient's safety in mind. If you have a reason for wanting that second IV, stand up for the patient. That's your job, is to advocate for the patient. No, I need a second IV. You need to give me 5 minutes to start the second IV, and then we can prep and drape. Sometimes you will be rushed. Sometimes you will have that annoying foot tap going on from the surgical team, the surgeon, but you have to stand your ground. And if you believe they need a second IV, you need to start that second IV. If you need more reinforcements because you're being ganged up on, call your attending, call another anesthesia provider to back you. There's nothing ever wrong with that, because sometimes I will say, sometimes you do get ganged up on where they're in a rush, they're rushing you, and you feel like you're advocating for the patient, and yet they're still not letting you do what you need to do. You got to call your reinforcements to get to the bedside to help you advocate for the patient. That doesn't happen often, luckily, but it can. So I wanted to make a point, especially as like a new student, especially if you get left in a room by yourself and something happens, you have to, even if someone goes against you, even if the surgeon goes against you, even if the surgical team goes against you, you have to stick to your gut and know what's best for the patient and be able to voice that. And even if, again, and just have your reason that to why you want to do a certain thing. And most time, as long as you have a good explanation and reason, it's going to be respected. Okay. But if you just say you want it, like they're going to be like, well, we're also on the clock here. Come on. Like, unless you have a good reason, we're going to keep proceeding with prepping the patient. You're not going to have time to start your second IV. So again, making sure you're staying up for yourself and the patient, of course. So that kind of covers a lot of positioning, but again, and then especially if like you're prone, you guys, you should be checking the eyes every 15 minutes, or really for any kind of case, like what's on their case, like any kind of ortho case, they're getting banged around, like they're being whacked with big hammers and saws and, shaken on the bed. And I can't tell you, even like in an open heart, for example, we would do like, say, I don't know if it was like mini sternotomies that were kind of like that, where they would kind of put a little bit of a bump under one patient's shoulder to kind of tilt them a little bit. And notoriously, once they got the sternum open, they would just like almost like shake the patient a little bit to like get the surgical equipment. Like, I don't know, but every time it would happen, it was like the patient's head be like, "Bleh." So I had to really make sure that the patient's ear was okay, the head was still neutral, support it, put some extra rolls to keep the head from laying flat on its face, because they were kind of almost like, again, kind of had a bump under their shoulder. So they were supine, but they were a little bit turned. And so again, making sure the neck's supported at any time during the case, because again, the surgeon could rattle the patient a little bit when they're doing their actual procedure. There's also been times where, like, if you don't secure the arm good enough to the arm board, the arm could actually fall off the arm board. Yeah, you want to make sure that kind of stuff won't happen. You want to make sure you're really taping that arm on there good. They usually have these really nice Velcro straps that you can use, but if you don't have a Velcro strap, get tape. If no one can get you a Velcro strap, use tape. Don't secure it. I know they've kind of cut back on, they don't like you using tape, but if they're not going to provide you and go get you a nice Velcro, you're going to tape the arm, because you got to keep the arm safe from falling off the arm board. So they don't also have a shoulder injury after the case. So again, making sure you're checking on that during the case. If there's shifting going on, if you're going in steep Trendelenburg of any kind, again, the patient could be shifting on the bed. You have to just always be paying attention to that. And then there's some cases too, you guys, where you start supine and then you go prone. But again, you want to be checking the eyes every 15 minutes, especially during a prone case, because I mean, the patient could go blind. I mean, it's a matter of, you want your eyesight or not. How mad would you be if you had a big back case and woke up blind? I mean, part of that is a perfusion pressure thing. Part of it is, if they have pressure on their eyes, it doesn't take long to do some optic nerve damage, okay, from lack of blood flow, from just that little bit of pressure on their eyes. You also want to keep in mind too, with positioning, how much fluid are they getting? And, if their head is down for the majority of the case and you're slamming in 3 liters of crystals, they're going to have a lot of swelling in their face because they're on their head. So you have to be, and don't get me wrong, there's a fine line when you have a case like that and they need fluid resuscitation. You have to get them what they need. Are they losing blood, or are they losing insensible loss? What do they need? Can you get some albumin in them to give you more leeway versus all these crystals? You have to be very cognizant of how much fluid you're giving them, especially if they're in a position during the case that's going to cause orbital swelling. So positioning plays into a lot. As you can see, it can affect your fluid resuscitation. It can affect the patient, how they wake up, whether they're comfortable or not. So it's a very, very important step. And I want to say that's probably one of the first things, again, that you start doing after you get through the induction phase. And I also want to make note here that, I don't know if you guys have noticed, but, after the induction phase, okay, maybe if you're lucky enough to have computerized charting, you can click a button that takes you 2 seconds, fine. But I have not mentioned that you do any charting up until this point, okay? You don't really do charting until you're in the middle of the maintenance phase. Okay. The first priority is getting through the induction safely, making sure the patient's ventilating, vital signs are stable, and then going to the positioning. Okay. And then the next things you want to do in the maintenance phase is you want to double check on antibiotics. Have they already received antibiotics, or do they need antibiotics? And then if they do, is there a redosing of that antibiotic? And what is that? Is it Ansteph every 4 hours? How long is the case? And then what I would do is, based on when I give the antibiotic, I would make a mental note of the time. And then if I knew the case was going to be longer, I put a reminder in the computer system to alarm at me to redose the antibiotic. Back in the day before computerized charting, and again, you can still do this with computerized charting, you could just write yourself on a piece of tape and put it somewhere where you would visually see it. Redose antibiotic at 1400 or whatever the time would be. But just, you don't want to forget that step. Okay. And also, when you do redose an antibiotic, tell the surgeon, tell them, because what if they're on skin and they're closing? It's probably not worth redosing an antibiotic if they're already on skin. Okay. So typically you only redose antibiotics if you're actually still open and operating, but it never hurts to run it by the surgeon. Maybe the patient's at higher risk for infection because they're a brittle diabetic, or whatever the reason may be. Maybe they'll still want it. So I always communicate that with the surgeon, not only just so that it's kind of like a second, like, do you really want the second dose of antibiotics if you're almost done? Or it could be just so I gave it, so they know you're staying on top of it. Because again, it's a trust thing, you guys. When you're doing the anesthetic, you're a team. Your approach is a team effort. And so you want to build that trust. And if the surgeon knows you're staying on top of dosing the antibiotics, they're also going to think, okay, she's not only staying on top of dosing the antibiotics, she's probably staying on top of other things too during the case. I don't have to worry as much. It's really building that trust relationship that, you know what's going on. And the more you do this and the more you can communicate, the more respect you're going to get. And overall just makes the whole operation go much more smooth. Okay. Versus them having to say, hey, have you redosed the antibiotic? I mean, they're busy, they're operating. They're not your stopwatch. Okay. So it's really your responsibility to keep track of that kind of stuff for them. Same thing, like if you were to give heparin and you have to wait 3 minutes to check an ACT, it's your responsibility to time that heparin dose and tell them when the ACT is due. Okay. You have to say, or like maybe 3 minutes, maybe you're not even doing an ACT. Maybe you're just giving a dose of heparin so they can actually clamp and do their vascular part of the procedure. It's your responsibility to let them know when it's safe for them to clamp, meaning they need to let that heparin circulate. And it's your responsibility to hit the timer to let them know when it's been 3 minutes. Okay. So something to keep in mind too, that's also your responsibility. I kind of got off topic with the order of things, but again, so we've just done positioning, we've confirmed antibiotic. And so obviously during all this positioning, doing the antibiotic, one thing you're always continuously doing, you guys, through the induction, maintenance, and emergence phase is managing vitals. You're giving fluid, you're treating blood pressure, you're titrating anesthetic gases, you're titrating ventilation. So even though I said our main focus is positioning, our main focus is asking about antibiotics or whatever, checking IVs, checking eyes, you're also simultaneously watching that blood pressure, simultaneously listening and looking back at your ventilator, making sure that they didn't, that they're adequately ventilated. You'd be surprised, especially during like positioning, you can accidentally pop off one of the circuits from like the main machine. I mean, your machine will alarm at you, but circuits can get disconnected, so it happens pretty frequently. So you have to always be paying attention to not only the position of the patient, but your lines and your ventilator tubing. Also always, you guys, I didn't mention this, but please, when you're repositioning your patient from supine, prone, I mean, you'd have to prone, but like, let's just say lateral, you're going lateral, disconnect your patient from the machine. You don't want to extubate the patient by accident, or maybe they have to move them way down the bed because they're operating on the ankle and they have to move them. So like literally their head's halfway down the bed. Disconnect them from the ventilator. It's just, even though if you have extra slack, just disconnect them. Make sure you're doing some recruitment breaths after you reconnect them, but it's just, you don't want to take a risk of extubating your patient, especially not that you would do it any other time, but what if you had a difficult airway? You need to be guarding that. Is like, you got to make sure that airway is secure at all times. That's also, again, your responsibility to make sure during the positioning and everything of the case. Okay. So again, you're managing vitals a lot during the maintenance of the case. Now, I will say, depending on the case, you're going to have some time here. Okay. Now, that's not always the case. Sometimes you literally go from induction to the maintenance phase, which is like super quick, and then you're waking up. Okay. And those cases are hard, especially if you're new. Okay. So if you're a new student, even an experienced student, even for CRNAs, you guys, even for experienced CRNAs, quick turnover cases are challenging. Okay. Because you're expected to do everything in just a short, brief moment. And so you get really good at trying to figure out prioritizing your tasks and your time. And believe me, I've been in PACU charting before because I haven't had time inside my case. Now, that being said, hopefully you work at a facility that gives you that time in between cases, because when you're working, like let's say at a surgery center where it's very, very quick turnover, you may not have a lot of time to catch up on your charting and recovery. You really have to just do your best and stay up to stay up on your charting, because they're going to be going to get that next patient as you're dropping off in PACU. So it's very, very challenging to work at a surgery center where not only are you turning over your own machines and getting ready for the next case, but you have quick cases in your hand charting. And so maybe you don't have, your focus is on the patient, so you're not charting during the case. And it can be hard. As you can see, it can make your head spin. You're like, especially if you're doing that all day long. But I will say most hospital systems that you're probably going to be starting off, especially as a new student, are probably going to be more like the typical hospital systems that are, this turnovers, you might have 10, 15 minutes. So it's really not as big of a deal like it would be in a surgical center, okay, where the turnovers are very quick. But keep in mind too, if you're doing a quick case, there's only going to be a few sets of vitals to chart. You're probably going to chart the standard induction, the standard positioning, all those things. So there wouldn't be as much to chart as there would be, like, say, in an open heart case, for example. But either way, depending on the case, after you get the patient settled and do all those things I just talked about, you kind of go into the maintenance where you're maintaining their vital signs. That's when you do the bulk of your charting. Okay. Don't get me wrong. You can keep track of the times. Like maybe you put a little dot on, if you're paper charting, you could put a little I for induction, so an S for supine, or P for prone. So, time wise where things happen, and then you go back and you update your chart. But if you want to keep track of your timing, that's a good way to do it, is to put little letters that, and most paper charting have symbols on the actual record for you to reference. So you know that they're appropriate to use. You can't just make up your own symbols. You have to use what they actually say on the paper chart. If you're using a computerized chart, most systems nowadays are touch screen. Sometimes they're not, but if they are, you can just touch a button, mark an event, come back to that later. Or a lot of charting systems now are, they kind of have like a roadmap for you to follow. So you hit button, 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 and it's super easy. As long as you know what time you started your induction, it's pretty easy to fill in the rest of the stuff later. And then what's also nice about computerized system is it charts your vitals every 5 minutes. So that's one less thing you have to remember to do. If you're paperized charting, don't worry about the exact number. Like I remember as a student going, no, don't get me wrong, you need to have an idea. Don't make things up. I'm not saying that by any means, but to, like, let's just say the blood pressure is 125 and you're like, I got to draw this little upside down arrow exactly in the middle between 120 and 130. So they know exactly it means 125 systolic. Like, don't kill yourself that way. Like if you put it at where the systolic would read 120, and even though it was 125, okay, 5 points is not going to make or break the patient or anything for that matter. So please, when you're paper charting, it's you get close to where you need to be on the graph, okay? But they have little tiny boxes for you to get as close as possible, but don't worry about being like to the T 100% accurate. The pressure was 123 and I had to indicate that. So just do the best you can. But yeah, you can on your actual monitor, you can go and hit trends, and you can actually go back and look at old blood pressures, especially if you're like, well, I know they spiked, but I don't remember when they spiked, because I know I gave them some fentanyl. So maybe I want to correlate that spike with when I gave the fentanyl. So I'll have to go back and double check things. And so when you're paper charting, there's a little more work to do, because again, you're not going to be able to see that in real time, where if it's computerized charting, you're going to be able to go back pretty quickly and say, oh, cool, the pressure and the heart rate spiked here. That's when I dosed him with propofol, so I wouldn't move on the surgeon. It'll be a little bit easier for you to go back and estimate when you gave drugs with a computerized charting. Paper charting, you might have to go back in the actual monitor and actually look at things. But again, charting is always secondary to the patient, no matter what you have to do with the patient. I think new students have a hard time. They worry about getting behind in charting, so they want to chart. But if you turn your back to the patient and their next blood pressure is 50/20 and you're still busy charting, like you can't do that. Like, and I mean, granted, that kind of a blood pressure would be alarming, but it's still, what if you turn your back and you're charting, you think the patient's good and they're getting ready to make an incision, and now the patient moves and the surgeon gets mad. They're like, what are you doing? Like, are they, and they'll say, are they asleep? And you're like, well, yeah, they're asleep, but they're not deep enough. Okay. So you got to be paying attention to really critical parts of the procedure. Don't turn your back and do the charting. You always obviously want to make sure you're paying full attention while they do the initial incision, because you want to make sure the patient's optimized. Even if, I mean, don't get me wrong, you're not going to have recall. Even if you move, you're not going to have recall. However, do you really want to spike in blood pressure to 180 systolic and a heart rate of 145? No, you don't. That's not good for the patient. Especially if they're going to still have the reflux to move with pain. You really want to make sure you're doing the best to optimize them for incision. So you want to be paying attention to that part of the case for sure. Not that you don't pay attention to other parts, but you know what I mean? You want to have all eyes, hands on deck during that part of the case to make sure that they're optimized. And essentially you want to actually pre-plan for that as well, meaning 5 minutes before what you think incision is going to happen, you want to make sure that you know the patient is deep enough, the patient has enough narcotic on board, whatever it may be. And sometimes you have to like let some hypotension ride out for a little bit, because again, maybe their pressure's kind of soft, kind of saggy, and they just need the knife. You just have to kind of be patient. It's kind of hard to look at, but what if you gave some neo or ephedrine, because you're like, oh, I don't want a pressure of like 80/50. Oh, but they're getting ready to make incision. Oh, what am I going to do? What am I going to do? And so like, I'll just give a little bit of ephedrine. So you gave like 5 milligrams of ephedrine, and then their next blood pressure is, one, like, I don't know, 110. I mean, 5 ephedrine probably wouldn't raise it that much, but some people are really sensitive to ephedrine and it can, and then they make incision and now they really skyrocket their heart rate and their blood pressure. So you know what I mean? So you want to make sure you're paying attention to that, so you can easily titrate your anesthetic gas and give them more pain medicine and that type of thing. But like once they've made incision, the patient's been stable for a few minutes, that's when you can go ahead and start paying attention to your chart, always while listening and occasionally looking to make sure that things are still smooth. Okay. I always was told as a student, you want to scan the room about every 5 minutes, and it doesn't necessarily mean like you turn your head all around, but you want to be listening, you want to be looking, you want to always be kind of scanning everything that's going on, the positioning, the urine output, the vital signs, what the surgeon's saying. You want to be listening and observing the whole time, even while you're actually charting. Okay. Because you're eventually going to pick up on little cues, like you're going to hear certain sutures, or you're going to hear, hand me the stapler, and you're like, okay, we're done. So you really always have to be paying attention to what is being said and what kind of tools or instruments are being requested, because it's really going to clue you in as to where you are in the case. And especially when you're new, you're not going to know when the case is going to end. And you're like, well, I don't know if we're almost done, and there's a lot of times where I still don't know if we're almost done, because sometimes it's an unfamiliar case even to me. Or even though it's a familiar case, this case is going to be a little different than the last case. Maybe there's a medical student who's going to close. I don't know, so again, things are not always the same. Just because you're doing 2 lap choles does not mean they're both going to be about the same speed. You also get to know what surgeons are fast. Some surgeons are quicker than others. And so you're going to get more familiar the more you do it, but initially you're not going to know. So you really have to be paying attention to what they're physically doing on the field to really know. about how long of an estimate of a case it's going to be. Now, during this maintenance phase, you did the charting, the patient's stable, they look great. But again, if they don't, then you give more pain medicine, you give blood pressure medicine, you give fluid, whatever, you watch their urine, you're always doing things like that. But you also have to keep in mind, well, what's next? What's next in my day? I have, 2 lap appies, but what if you have, like, let's just say, what if you have a AV fistula and the next one is a carotid? Okay. A carotid, there's a lot to set up for in a carotid. You need an A line, you're going to need a couple big bore IVs. So you're going to have some fluid to get ready. You're going to, there's different drugs involved. You want to make sure you have Clevaprex on hand. If you don't use Clevaprex, Cardine also is very popular, but both calcium channel blockers, they just lower the blood pressure. Carotids, you got to make sure you have your pressors lined up and ready to go because they swing, they go up and they go down, they go up and they go down. It's crazy. So Clevaprex is definitely a necessity, or Cardine, to have for a carotid, because the last thing you want them to do is get extremely hypertensive on you during a really critical part of the case. So anyhow, that's a lot to set up. So you're in the middle of this AV fistula. Those are really usually done under MAC anesthetics. Not that MACs can actually be more labor intensive than a general, because now you don't have a secured airway. The patient could be obstructing, which would require your hands on deck to open the airway. So you might not actually, when you're doing a MAC, you guys, you might actually have less time to prepare for your next case than you do just an endotracheal tube. Okay. Endotracheal tube, you can walk away from an open airway that, well, if they have an oral airway or whatever they have, you may have to use more of your hands to make sure the patient is safe the whole time. Okay. So it can actually be more work and harder to pre-plan for the next case. But either way, you have to find time to get your drugs ready, get fluids ready, kind of read up on the patient if you can, if you have computerized charting, look up other history, make sure you have any questions in your mind that you maybe want to address before they start the next case with the surgeon or the attending or the anesthetic team. So those are some things you do during the maintenance phase as you kind of prepare for the next case. And again, make sure you're locking up your drugs. You don't want to leave drugs out. That's always a big no-no. One thing I will suggest is to maybe potentially not drop narcotics until you know for sure the patient is in-house. I mean, really, you shouldn't drop any meds until you know the patient is in-house. But I know a lot of you as students are going to want to get ahead. Okay. So you're like, I'm going to get ready for the next 4 cases. I'm going to have drugs ready for all 4 cases. And it's also very common to do that at a pediatric hospital where the turnaround is very quick and there's a lot of a huge lineup of cases. However, you could burn yourself if the patient doesn't show, they get canceled, and now you have these drugs, they're just going to be wasted. And then narcotics need to actually physically be wasted with someone else. So at the very least, just don't drop your narcotics if you're ever questioning whether the case might get canceled. I'm not saying don't have a syringe labeled and ready to go and the drug out. Just don't crack the top until it'll save you. Trust me, it'll save you from having to find someone to waste with you. Trying to find tips to save you guys time, believe it or not. Because again, I've learned the hard way where I'm like, oh, now I got to find someone to waste this fentanyl, or you got to transfer the drug, which is fine if you have a Pyxis. But if you don't have a Pyxis, like an Omnicell, those can be a little more labor intensive and a run around where you have to take one out on another patient and return it. And then it's just easier if you just don't crack the lid of the medication until you know for sure the case is going. So anyhow, so at this point, you've gotten ready for your next case. Now you have to start thinking about wake up. Now, don't get me wrong. You should really be thinking about wake up before the case even starts, meaning you should have a game plan from start to finish. You should think about, this is how I want the case to go in the beginning, middle, and the end. That should happen prior to any anesthetic taking place. You should actually, in your mind, mentally prepare for the entire case. However, when you're in the middle of the maintenance phase and you're actually really, truly getting ready to wake up here soon, you want to say, okay, has anything changed in my game plan for wake up? Maybe they had a bronchospasm with induction. Maybe I should give them, and maybe we had to give albuterol. Maybe they should have their dose of albuterol before we actually wake up. Okay, that's what I mean. Has there been any change from your initial plan that maybe you need to take some extra precautions during your wake up? You should be getting ready for that at this moment. Okay. And kind of preparing for it. Are they maybe going to stay intubated? Maybe they were going to be extubated, but now they're staying intubated and going to the ICU. Are you ready to give an ICU nurse report? That kind of thing. So again, just think about, has the plan changed? And if it has, what am I going to be doing differently? And obviously you always want a smooth emergence. Not that anyone wants, I want a sloppy emergence, but they always say have a smooth emergence. I'm like, well, okay, I sure hope so. I plan for that every time, but it doesn't necessarily mean it's always going to happen. So what I encourage you to do, especially if you're new, is to think, okay, what could go wrong during this emergence and what would I do? meaning if they had a bronchospasm, if you extubate too soon and they have a laryngospasm. What if they just don't wake up? What if they just are super slow to wake up? Like, think about what could go wrong and what would I do and how would I try to troubleshoot these problems? Because it will happen. I'm going to be honest with you guys. Things won't always go as planned. Most of the time they do, but you want to be prepared for the times that don't go as planned and being able to troubleshoot what could you do differently and how could you make the situation better. Okay. A carotid, for example, has to have a really brisk wake up, be able to move all four extremities, stick out their tongue and pretty much recite the alphabet. Yet they can't buck on that tube, so it's extremely hard case to wake up. Okay. And so what are you going to be doing? What's your plan to help that situation? Are you going to be putting lidocaine around the endotracheal tube cuff? So maybe they're going to lose a little bit of their gag reflex from the endotracheal tube. Are you going to give IV lidocaine during the wake up? What kind of narcotic are you going to use? Are you going to use just fentanyl? Or are you going to maybe try just like a smidge of sufentanil? Giving 5 mics of sufentanil, like during a carotid, like if you just use sufentanil, it's actually a really nice drug because you really do blunt that coughing reflex. But again, you can't over narcotize a carotid because you really have to have them be brisk and awake. So you have to be really careful. You cannot give tons of fentanyl to a carotid. I've been burned, you guys, on 100 mics of fentanyl on a carotid that I gave at the beginning of the case, that I didn't give anything additional. And I went to wake them up and they needed Narcan. Now that only happened once. And it was probably just like total fluke. But you have to be very cognizant of giving narcotics to carotids. So again, what's your game plan to have them be awake and not cough on the tube? I'll tell you right now, a key to waking up a carotid is to get the gas off. Like, the gas is going to screw you 9 times out of 10. Narcotics is probably the other big culprit, but the gas, you got to have a plan, but yet you don't want them to move while they're still closing. So again, what do you plan on doing? Your backup plan maybe is give a little bit of propofol, but you don't want to give too much because then they're going to be even sleepier. But propofol is another great drug. If you just gave a little bit, like to kind of blunt a little bit of like their startling awake kind of during the case, maybe get the gas off early and just give a smidge of propofol. And that way, you're kind of blunting a little bit of that like quick wake up, kind of thing, or nitrous, whatever you think is appropriate for the patient to kind of bridge you to a quicker wake up. Nitrous, as long as it's appropriate for the patient, it's a great way to get the actual anesthetic gas off quicker. And obviously making sure that their vital signs are stable during wake up, because another thing with a carotid is they can get very hypertensive with the wake up, and you don't want that either. So they're challenging cases. But again, so you're preparing for the wake up, you guys, you're kind of trying to think, what does the patient need to make sure that this emergence is as smooth as possible? Am I going to be planning on pulling this endotracheal tube deep? How awake do they need to be for the end of the case? There are some like max, for example, like you don't really have to wake them up as long as they're breathing and exchanging fine. Leave them and then take them over to recovery nice and sleepy. They can wake up over there. The caveat and the catch to that is, you also don't want to neglect the fact that maybe they need more pain medicine. You need to be, even if they're sedated on propofol, you can tell if someone is having pain. You can tell by their vital signs. They may not be awake and arousable, but you're going to be able to tell based on their vital signs and their respiratory rate that they're having pain. So you don't want to like keep them sedated the entire case and bring them to recovery. And when they finally do wake up, now they're in excruciating pain because you didn't treat that. So you have to make sure that you're also still taking that into consideration as well when you're either pulling something deep or taking someone over sedated. Another thing to keep in mind too is certain facilities will not appreciate an oral airway. They will get upset because an oral airway is an airway. And so a lot of times the PACU, the nurses physically can't leave the patient, and they have more than one patient to take care of. And so when you have an oral airway, they can't leave the bedside, and that makes them very, very angry and just it's not ideal. So they'll literally say like, we can't have this airway, so and so that's actually really hard, especially like at a surgery center where the turnover is really quick and you want to just bring someone over. Typically what I would do if I couldn't time it right to get them more awake by the time they got to recovery, I would give report and then I would yank the airway and try to get them in a position where they're supporting their own airway over in recovery. Obviously I would try to do it prior to that, but it didn't always work out. Timing can be very hard, but yeah, some facilities don't necessarily like oral airways and recovery. Plenty of them are okay with it, but I'm just throwing it out there that there are going to be places who give you a hard time about that. I rotated through facility as a student who we would bring them over with LMAs, which essentially is just an oral airway. It's just a fancy one. But they would pull all their own LMAs over in recovery. I even rotated through a place that would extubate patients in recovery. Like if it was a pediatric hospital that did like, so a 12 case lineup of TNAs, we wouldn't even extubate them. We would just do the case, bring them over. The PACU nurses would extubate the patients. Yeah. But again, that was one place where I currently work. It's a pediatric hospital and they do not do that. So don't take that for like every place is going to be like that, because they're all a little different. So anyway, so we're going to get into the next episode. We're going to kind of go into more of emergence, but I wanted to kind of give you guys some ideas of what you start doing during the plant or the maintenance phase to kind of prepare for emergence. I probably went more into detail than I probably should have for the emergence, but we'll go into even more detail in the next podcast episode. So I hope you guys enjoyed this, and take care. And of course, if you guys, I don't know if you guys have purchased your ticket for CRNA School Prep Academy conference, but it is quickly approaching. It's happening on October 23rd. We did move virtual. I'm excited for it. I managed to find a virtual photo booth, which I've never even heard of before, but I was like, there has to be some way that we could take pictures together, because I want to create a memory for you. I want this to be the start of your CRNA journey, whether you're in nursing school, whether you've been an ICU nurse for 5 or 6 years. The conference is going to give you so many tangible takeaways, and I really hope to see you there. You still have time to grab your ticket. If you grab your ticket by October 15th, we are shipping door prizes to your home. So how cool is that? You're also going to be getting breakfast via DoorDash, a Starbucks gift card, however you want to use the gift card to get breakfast. But you're going to be getting spoiled virtually. Okay. We're going to have little breakout rooms so you can actually meet program faculty face to face. So it's not just going to be a giant Zoom room. It's actually going to be in a platform called Hopin that is going to allow kind of like a stage and different rooms. And so we're going to have our normal lineup of lectures and guest speakers. And then we're going to have, with like breaks, built-in breaks, the mingling session, we're going to have little smaller rooms where you can pop over to South College and talk to the program directors, Emory, University of South Carolina. So I'm super excited about that. So again, in the virtual photo booth, we can actually have customized backdrops. We can put little face masks on each other and a stethoscope or a laryngoscope blade. It'll be fun. So, and we can actually have a room of 10 people getting a picture together. So you can print it out, put it on your desk. So your journey for CRNA you're going to create that memory, which I think is a super vital part of planning your success in your future, is to create memories that you can visually see going forward. So I hope you guys will join us again. That's October 23rd. If you join after October 15th, you can still get your door prize. We just can't promise it's going to be there in time for the conference. We might look into like doing some rush shipping, but we are saying that anything after October 15th, there is a risk that you may not get your door prize in time for the conference. And I want you to get your door prize in time for the conference. So definitely try to get your ticket before. We're going to do something fun at the end, and it's going to be inside your welcome package. So I'm not going to spoil the surprise. So I'm going to try to keep my mouth shut, but yeah, go ahead and get your ticket today. And you guys, will see you next week for the next episode on talking about emergence. You guys take care. Bye-bye.